Hi all, today's topic we will be discussing about dyssynchrony in pediatric ventilation. So what is asynchrony or dyssynchrony? This is something that we have heard our intensivists speak about, isn't it so? If you hear some background noise, it's the crows and pigeons trying to listen in on our lecture. Right. So dyssynchrony is nothing but a mismatch between what the patient wants and what the patient gets. So the ventilator's respiratory rate or the drive is not matching that of the patient's respiratory requirements. So what? So if it does not match, so what? The patient is going to have discomfort. The patient is going to try to breathe against the ventilator, buck against the ventilator, and he or she will have increased work of breathing. This is not going to help the patient rest his or her respiratory system, resulting in prolonged ventilation. And as for us on the other end of the ventilation, we see that the patient is trying to fight the ventilator or struggling too hard, and so we think that the patient is requiring more sedation or maybe even more paralysis, but that comes with complications of its own. Hence the importance for us to recognize the dyssynchrony that exists in any mechanical ventilation. So what determines synchrony? So only if you know what determines synchrony, then you will know what causes it not to. So your patient has some sort of lung problem and you set the ventilator. So there is a patient ventilator interface between the two of them. If the patient and the ventilator are not interacting properly, could be due to any reason, you will have some symptoms and some signs. The onus is on us to detect these symptoms and signs so that we can respond appropriately. How do you recognize that? The patient can have increased respiratory activity. Accessory muscles can work hard, patient can cough, agitate. You will see that the heart rate is rising, your respiratory rate is rising, but the saturations are actually falling. So this should give you a clue that the patient is not happy with whatever settings that you have approved for the patient. So recognize that and respond to it appropriately, which is what we will be discussing in today's class. The ventilator, on the other hand, is intelligent enough nowadays. So it gives out alarms, it gives you quantities as to what the patient is receiving, it gives you graphical displays of what is received by the patient and what is given out by the patient. So you need to recognize that, and again you need to respond appropriately. Even though ventilator does do some amount of responding, but you need to help the ventilator do it better. So before we go into the dyssynchrony part, recall some basics. Always remember, spontaneous ventilation means it's a negative ventilation. Inspiration means there is a negative pressure inside the thorax, and expiration means there is a positive pressure exhaling out. Whereas in a ventilation or a ventilator given ventilation, it's a positive pressure ventilation, meaning air is being pushed in. Whereas in a spontaneous ventilation, air is being pulled in. Okay, a ventilator pushes in air resulting in positive pressure. During expiration, there is negative pressure resulting in passive exhalation of air. And you already know what is trigger, limit and cycle. Trigger is what determines the start of inspiration, limit or target is what sustains the inspiration, and cycle is what ends the inspiration. So what are the problems in synchrony? It can be a problem in the start, it can be a problem in sustaining, it can be a problem in end. So a trigger dyssynchrony, a limit dyssynchrony or a cycle dyssynchrony. So trigger dyssynchrony can be broadly classified as ineffective trigger or extra trigger. Ineffective is patient is not receiving enough. Extra is patient is receiving too much. Ineffective can again be classified as delayed or missed, and extra as auto trigger and double trigger. Limit dyssynchrony is a flow dyssynchrony. Cycle, the inspiration can end prematurely or the inspiration can be delayed or ending delayed. So premature cycling or delayed cycling. So we will see one by one. This is the diagram that we will be using throughout the presentation. So this is a pressure time scalar where you have the start. So this will be your trigger. In between throughout will be your limit or target, and the end of inspiration will be your cycle. This is your expiration part, and this whole thing from the start of your trigger to the cycling is your inspiration part. So let's start with trigger dyssynchrony. And in trigger dyssynchrony, ineffective trigger, example being missed trigger. So missed trigger is what? Patient is trying to breathe, but the ventilator is not detecting that, not detecting the effort of the patient. Okay. So what could be the problem? The patient is trying to take a breath, isn't it so? So here if you see, the patient is trying to take a breath here, as evidenced by the negative deflection here, as evidenced by the flow change that is happening here. This is a pressure time scalar, this is a flow time scalar. Okay. So can you see this negative deflection? It means patient was trying to actually take in some air, isn't it so? Take in some of the pressure that is there in the tubing, but this is not followed by a breath by the ventilator. This means this trigger was missed by the ventilator. Why? Either you have set the threshold to be too high. Say for example, this patient is capable of initiating a spontaneous breath at only -2 centimeter of water, for example. But you have set the trigger threshold as -5. The patient needs to take a breath enough to reduce the pressure to -5. Only then the patient will receive a breath, isn't it so? So if the trigger threshold is too high, then again you will have the problem of missing the trigger. Or the patient's respiratory effort on the other hand is very weak to achieve the threshold that you have set. That is another possibility. Or you have chosen the wrong trigger. See, wrong trigger I will explain you with few examples. Okay. So here this is the patient, the ET tube. This is the inspiratory limb, expiratory limb. Okay. And you have the flow of gas at 10 liters per minute. Okay. So from inspiration 10 liters per minute, and the same thing is going in at expiratory limb back to the ventilator. So if the patient is taking a breath, if 3 liters per minute is going inside the patient, imagine. Okay, so the expiratory limb will receive only 7 liters per minute, isn't it so? Because out of the 10, 3 is going inside the patient. So this flow dip is detected as the trigger, and the patient will receive a breath if you have set a flow trigger. Correct? Am I right? I hope you are following till now. So imagine a situation where the patient is receiving a nebulizer. Nebulizer you will give at the rate of say minimum 5 liters per minute you are giving, let's say. Okay, so 5 liters per minute of a nebulizer you are giving. So what happens in that case? You have this 5 liters adding on with the 10 liter from the inspiratory limb. Am I right? So the patient or the limb is actually receiving 15 liters per minute. If the patient has to increase this flow trigger, the amount of volume that has to go back to the expiratory limb should be less by 3 liters per minute, isn't it so? Or approximately only 7 liters per minute should reach the ventilator in order for the ventilator to detect that patient has taken a breath. That's what happened here, isn't it so? 10 liters per minute went in, only 7 liters per minute came back in. So the ventilator detected that the patient has taken 3 liters of air, 3 liters of flow. So if you are giving a nebulizer at 5 liters, so out of the 15 liters that is going inside, only 7 liters has to come back in, because ventilator is not going to account for you adding on to the nebulizer. Correct? So patient has to take in how much? Patient has to take in this 5 from the nebulizer and extra 3 from this 10 in order for the expiratory limb to receive only 7. So patient has to take such a deep breath in. If the patient is taking such a good breath, why will he or she be on ventilator? Right? So patient will not be able to take in this excess ventilator flow and this nebulizer flow. So if a patient is on nebulizer, either change the flow trigger to account for this extra volume or change it to a pressure trigger. Okay. So if you change it to a pressure trigger, then flow is not going to affect it too much, and patient will still be able to breathe despite being on a nebulizer. Okay. So that's why a wrong trigger option was given. On the other hand, imagine a patient who is having auto PWP, as in the case of asthma. So if the patient is already having extra pressure inside the lungs, so the patient has to take in a larger breath to reduce the pressure too much to trigger the pressure threshold that you have set by you. So in this condition, you may change to flow trigger, although recent studies say there are not much differences in the way that you set a flow trigger or a pressure trigger in case of auto PWP. But just remember, any condition with air trapping will require you to reduce your threshold. Okay, make it easier for the patient to breathe, because already patient is having some volume inside, some pressure inside. Patient has to overcome that extra pressure and then take some more breath in order to touch your threshold. Alright. So, rectification for a missed trigger will be for you to adjust the trigger sensitivity or change the trigger type depending upon whichever works for your patient. Next, we will discuss about delayed trigger and then come to your auto triggering. So, earlier we saw missed triggering, isn't it so? The ventilator missed it altogether. But here there is a delayed trigger. If you see in this diagram, right, this is the esophageal pressure waveform and this is your pressure time scaler. Okay. So, when the patient is trying to take a breath, so patient has triggered, ventilator is giving a breath, yes, but if you see the time of when the patient started the trigger versus when the ventilator started the breath is actually two different things. Okay, patient wanted the ventilation from here. If you see, the esophageal pressures have started dropping here already, because spontaneous is a negative pressure ventilation. You see the dip in this esophageal pressure, but the ventilator detected this dip later on. Got my point? So, in the lower figure, esophageal pressure, if you see, the patient has started breathing early. If you draw a vertical line, you see that nothing has changed in the ventilator graphics. The ventilator has detected that the patient is taking a breath later on only. Okay, so there is a delay in patient initiation versus ventilator breath. Again, the possible causes are very similar to that of your missed trigger. Increased resistance in the airway, decreased compliance, decreased respiratory drive of the patient, muscle weakness in the respiratory system, auto PWP, or the settings that you have set is too high. So, how can you intervene? If there is too much resistance, give bronchodilator so that the airways dilate. If the patient is having decreased respiratory drive due to too much sedation, then reduce the amount of sedation that you are giving. If the patient is having an electrolyte imbalance resulting in respiratory muscle weakness, correct those electrolyte imbalances. If the patient is having too much auto PWP, correct the cause for auto PWP. That can again be helped by your bronchodilators. The settings are set too high, then reduce the trigger threshold. So, these are the causes for your missed and delayed trigger and how do you troubleshoot them. So, these are all ineffective triggering. Now, coming to too much triggering. Okay. So, if you see this waveform, you can see that there is a breath after breath after breath after breath after breath, there is continuous breathing activity that is going on, and that is not how you would have set the ventilator, isn't it so? There are too much negative deflections that are happening, there is inappropriate triggering happening. And you see that the set respiratory rate is 20, whereas the total respiratory rate is somewhere around 40 or 50. Okay. So, this inappropriate triggering is usually due to extra pulmonary reasons. Okay. So, remember it like that. Extra triggering is extra pulmonary reasons. Usually there will be not a problem in the patient system. It will be something outside of it. Like for example, excess condensation in the tubings resulting in water oscillations. That will be detected as the patient trying to breathe, and this will trigger ventilator breath. If you see that every time it is a triggered breath. Ventilator is assuming that the patient is triggering when in actuality it is not so. Or if there is a small leak resulting in dip of pressure, or if the cardiac pulsations are getting transmitted to the airway, that will again be detected as a trigger. Okay, so in these situations, try to find the cause and try to adjust your trigger settings. It's always a balance. If you set too high a threshold, then there's a chance that it will become ineffective triggering. If you set too low a threshold, then you end up with the problem of auto triggering. Double triggering I will discuss with cycling, and I will tell you why later. So now that we have completed the trigger problems, we will talk about target problems. So this is a volume controlled ventilation. Volume controlled ventilation, you see that the flow has not changed, whatever be the underlying problem, it is going to remain same. Okay, so whatever you have set is what is going to deliver to the patient in flow. in your pressure time scaler, you will see what is happening inside the patient. This is what we discussed previously, right? Volume controlled ventilation will give you a good idea as to the resistance, compliance, needs of the patient. If you look at the pressure waveform, if you see the pressure waveform, this is not nicely happening like this, correct? This is having a small dip in between. Why is this dip or devo happening? Because patient wants more flow. Patient is flow hungry. The flow that you are giving here is not satisfying the needs of the patient. So, patient is trying to take a deeper breath here. That is why you get this negative deflection, because normal breathing means negative pressure in spontaneous ventilation. That is why you have this small devo in pressure time scaler. Okay, so how do you intervene in this situation? When you see a devo like this, it means the patient is not receiving enough flow. So increase the flow, or you change the flow pattern. Suppose initially you have set it at a square pattern. You can change it to a decelerating pattern where the patient's initial demands are met easily and earlier. Or you can change the mode of ventilation itself to pressure control mode, so that the patient can take in how much ever flow or volume he or she wants. Okay, so this is how you intervene in a flow dyssynchrony. Next, coming to cycle dyssynchrony. The usual issue in cycle dyssynchrony is time. Either it ends too early or ends too late. So let's see what is happening when there is a delayed cycling. Okay, so here you have your esophageal pressure indication, and here you have your airway pressure graphic. You see that the patient has triggered, it is going up well enough, but then again there is a small spurt, isn't it so? Why is this positive pressure happening here? This positive pressure is because patient is exhaling. When the patient exhales spontaneously, there is a positive pressure generation. Correct? That is what happens in your spontaneous ventilation, and that is what is represented in this graph also. So, according to your ventilator, your total inspiratory time is this, represented in blue. But what the patient wants is, patient wants to end inspiration here and starts exhaling here, as evidenced by this spike. Isn't it so? So, the ventilator inspiratory time is more than that of patient's inspiratory time. The ventilator stops inspiration later than what the patient, or when the patient wants to stop inspiration. So, how can you remedy this problem? You can remedy this problem depending upon whatever mode you are choosing. See, either you can reduce inspiratory time if it is time cycled, for example, in case of your pressure controlled ventilation. Right? Pressure controlled ventilation is time cycled. In a volume controlled ventilation, how do you change? You cannot change your TI, no. See, TI is not how the ventilator gets cycled. That is what I am trying to mean. Right? So, your volume control, your volume is flow into time, or in other words, flow is equal to volume by time. If you shift it to this area, on this side of is equal to, time is volume by flow. So, here where the cycling factor is volume, in a volume controlled ventilation, you can adjust your time, that is your inspiratory time, by either reducing the volume or increasing the flow. Because ultimately what do you want? You want to reduce the inspiratory time, because that is what patient wants. If it is pressure cycle, it is going to be straightforward. You reduce the inspiratory time, then the patient is going to be happy. Here it is where the cycling factor is volume, in a volume controlled ventilation, you can indirectly reduce the inspiratory time by reducing the volume that is given to the patient, or increasing the flow that is given to the patient. Okay. So, this is how you tackle a delayed cycling dyssynchrony. So, here again you have this small spike which is showing that patient is exhaling. How will it look in a flow waveform? So, here you have a decelerating flow pattern, initial drop in flow and then actual drop. The initial drop is patient is exhaling out, okay, and the later drop is ventilator is taking out the air, there is negative flow, correct. In a volume waveform, if you see, this is how it is going to look. So, initial rise whenever there is your inspiration, then there is a small dip in the volume because patient has started exhaling already, and then there is a larger dip when the ventilator starts exhaling. So, you will have 2 dips in your flow and 2 dips in your volume waveform. This is your delayed cycling. Okay, so delayed cycling problem is time where the ventilator's inspiratory time is more than that of what the patient wants. So, you have to reduce the inspiratory time. If it's pressure controlled, you reduce the inspiratory time. If it's volume controlled, you decrease your tidal volume or increase flow. What about premature cycling? Okay, premature cycling again is also called as double triggering. That's why I told I will discuss it here. There are 2 types of double triggering, where this is more common, so we will talk about this first. So, here what you can see, this is again your esophageal pressure and this is your pressure time scaler. Pressure time scaler, and this is your esophageal pressure. Yes. So, you have the patient triggering. The patient is receiving the breath, trying to exhale out, but before actually exhaling, you have another breath that is coming in. Correct? So, there is double triggering happening. Why is this double triggering happening? When you see, actually the patient wants to inspire more. Patient wants more and more inspiration. So, this small negative dip is again detected as a trigger by the ventilator, and before the patient can actually exhale out or before the ventilator can exhale out, whichever way you want to look at it, because patient clearly does not want to, this will be detected as negative deflection, because inspiration in spontaneous is a negative deflection. Correct? So, this is detected as a trigger and another breath is provided. So, esophagus, if you see, patient wants this much inspiration. Okay? So, if you want to represent it like this is your patient's want, whereas what the patient is receiving is only this much. This is what the ventilator wants to give, whereas the yellow is what the patient wants to receive. So, the patient's inspiratory time is more than that of the ventilator inspiratory time. What will be the consequence of this? There will be hyperinflation or volume trauma. Why a volume trauma or a hyperinflation? Let's see. So, I have put it in 2 different modes here, a volume control mode and a pressure control mode. Okay. So, in a volume controlled mode, you see that the flow is set. Okay, there will be no change in the upstroke of the flow pattern, because that is what you have set. But what you will note is that patient is not having an expiration. Okay, patient is not having an expiration. Patient continuously wants to inhale. So, initial 1 breath, then again the second breath without any expiration at all. If you see the volume waveform, initially there will be a rise, say around 200 ml patient is receiving. Okay, without expiration there is another inhalation. So, another 200 ml patient will be receiving. See, in the second breath there will be doubling of the volume. Why? Because for every breath the patient is going to receive your set volume or set flow, to be more exact. Okay, irrespective of what the pressure is inside, because this is a volume controlled mode. No, the ventilator is not going to freak out just because the pressure is going up. So, the ventilator will still give another amount of flow to the patient, equal amount of flow. So, patient will receive equal amount of volume, but the pressure rise, if you see, is too much compared to that of the first breath. That is why there is increased chances of barotrauma if the patient is on volume controlled ventilation, because without expiration patient is receiving a second breath, resulting in too much pressure. You need to have extra pressure, no, to push in the same amount of volume. Imagine you trying to take a deep breath and you try to push out only 20% or 30% of air out. Then again try to take a deep breath on top of it. You are going to find it difficult, and that is what the ventilator is also going to perceive. On the other hand, if you do a pressure controlled ventilation, you have a pressure waveform that is set. You have another breath that is coming up, and your flow waveform, if you see, again there is no expiration, but the second flow is less. Why is this happening? Because with first breath patient was delivered 20 centimeter of water. Second breath again patient was delivered 20 centimeter of water. but the volume or flow that can go inside for that much amount of pressure will be less, because it is already filled with X amount of ml. Okay. So second breath, even though patient is receiving same amount of pressure, due to already pre-existing 20 centimeter inside, patient will not receive that much flow, it will be less, and patient will not receive that much volume, it will be less, even with the second breath. So volume controlled ventilation, if there is a problem with this double triggering or premature cycling, there will be doubling of volume, whereas in a pressure controlled ventilation, there will be excess volume, but it will not double, it will be less than double. But whatever, at the end you are going to end up with volutrauma or hyperinflation. So how do you remedy this? Since patient wants to take a deeper breath or a longer breath, adjust the inspiratory time. No, give more time for the patient to ventilate. If it's a pressure control ventilation, you can directly increase your inspiratory time. If it's a volume controlled ventilation, similar to what we discussed earlier, time is volume by flow. So either if you increase tidal volume or decreased flow rate, patient can take a longer duration of breath. Okay, so this is one form of double triggering, or a common form of double triggering, premature cycling, that you see. Another is called as reverse triggering or entrainment. Entrainment is a ventilator driven breath or a control breath will simulate that of diaphragmatic contraction, resulting in triggering and assist breath immediately after a control breath. That will again look like this, but only thing is you will be able to see that the control breath followed by a assist breath. Okay, because the first one is a control breath, whereas in the previous one it's probably both are triggered. Okay, so whatever may be the underlying reason, you need to give more inspiratory time to the patient. That's it about your ventilator dyssynchrony. I hope I was clear enough for you guys to understand what I am talking about. So dyssynchrony is where the patient's needs are not met by the ventilator appropriately. So you have a mismatch. It can be either in the start, sustenance or end of inspiration. So identify where the problem occurs depending on the waveform and adjust the settings accordingly to give the patient a better ventilation. Thank you guys for listening patiently. Share this among your academic groups if you found this useful, and if I have made any mistakes, you can point it out, or if I find out something, I'll definitely update it in the description box below. Thank you, bye bye, and all the best.